we're going to be considering the structure and function of the heart. And then we're going to move into looking at cardioregulation that has to do with the components that affect cardiac output. So we're going to start and we're going to look at the anatomy of the heart and the conduction system because that's important for understanding how arrhythmias occur. We'll take a look at the cardiac cycle, so what it means for the heart to rest and then push out blood. And sometimes we think of a cardiac cycle as like one heartbeat. We're going to look at what regulates our cardiac performance. And so there's different components of that, if you remember from your anatomy and physiology courses. So we'll look at preload, afterload, our cardiac contractility and what regulates it, and also then our heart rate. We'll take a look at cardiac output. That's very important for understanding heart failure. And then we'll take a look at the organization of our pulmonary and systemic circulations as well to understand how they're related and how one can influence the other. So to begin, we're looking at anatomy. So we're going to look at gross anatomy and then histology of the heart muscle. So to begin, your heart, if you remember, it's approximately the size of your fist, and it's located in the thoracic cavity in an area we call the mediastinum, which means the area between the pleura of the lungs. It's not within that pleura, it's outside it, as you can see in this picture. So it's enclosed in a double wall sac that we call the pericardium, and that's there to protect and lubricate the heart as it beats. So we're going to take a look at the anatomy now, and we're going to start with the heart wall. The heart has open chambers or hollow areas that fill with blood. So most of us know that there are 4 chambers of the heart. The lining of these chambers is the very first layer of the heart wall, and then we're going to take a look as it builds out from there into the pericardium, or what makes that pericardial sac. So the innermost layer of the heart is called the endocardium, and it's lined with endothelial cells. So it's continuous with the lining of the blood vessels. The next layer, and we can see it here, is the bulky myocardium, which is made of spiral bundles of cardiomyocytes, or cardiac muscle. This layer also has in it a fibrous skeleton of connective tissue that acts as an anchor for these cells, and it also supports the blood vessels and the heart valves, and it's also acting as a sort of like a guide for the action potentials for specific pathways through the heart. The visceral layer is the epicardium, and it's going to be one side of the lining of that pericardial sac. We've mentioned the pericardium and the pericardial sac already. So if you remember, that's going to be a membranous sac that's going to produce lubricant, and that's going to help to decrease friction of the beating heart and to help to protect the heart. So part of what allows the heart to beat is the organization of the cells, or those cardiomyocytes, the muscle cells of the heart. These are also called muscle fibers. The fibers are striated just like our skeletal muscle, but they are different in that they are branched. So here you could see that branching that we have, and they also have interconnected cells. So between the cells, there are intercalated discs. The striations are coming from sarcomeres, and if you remember, those are the contractile units that contain actin and myosin. The myocytes also contain many mitochondria, and remember that the mitochondria are there to produce energy, and these myocytes need lots of energy because they have to continuously contract. And the cells then are interconnected by these intercalated discs. These prevent the cells from separating, so they sort of hold or button the cells together. So they hold them together when they're going to be contracting. But just like a button has holes in it for the thread, right? These intercalated discs also have passages in them that allow the cells to pass ions from one to another. So by each cell being connected to its neighbors, it allows the heart to behave as a functional syncytium. So if one cell receives the signal to contract, that signal is going to flow to all of the other cells in the heart, causing them to contract as well. So what it's working to do is to sort of guarantee then a heartbeat. Let's take a look at the chambers in more detail now. So the heart does have 4 chambers. The superior chambers are the atria, and those receive blood returning from the systemic or the pulmonary circuits. There are, between the upper chambers and the lower chambers, a heart valve, and we call it the atrioventricular valve that separates the upper from the lower chamber. The valves make sure that there's one-way flow of blood through the heart, and it prevents blood from backflowing. On the right, the AV valve is called the tricuspid valve, and on the left, it's called the bicuspid. The lower chambers are the heart's ventricles. And here we can see that the AV valves have strings that come down. They're called the chordinae tendineae, and they anchor or tether to papillary muscles in the heart wall and these lower ventricles. The right and left ventricle work as 2 simultaneous pumps that are going to pump the blood into either the pulmonary or the systemic circulations. To leave the heart, the blood must enter through the great vessels. So on the right side of the heart, the blood has to pass through the pulmonary valve, and then it enters into the pulmonary artery, where it will then go to the lungs. On the left side of the heart, the blood is going to pass through the aortic valve and go into another great vessel, the aorta. And once it's in the aorta, it can go into the systemic circulation or then travel throughout the body. So these valves that separate the ventricles from the great blood vessels are called our semilunar valves. We're next going to take a look at the pulmonary and systemic circulations. So if we look at the heart, we know that it can be thought of as a 2-sided pump, or another way to think about it are 2 pumps working simultaneously at the same time. As it contracts its lower ventricles, the blood gets ejected from the heart, and it can either enter the pulmonary circuit, which is going to bring deoxygenated blood to the lungs, or the systemic circulation, which brings oxygenated blood to the body's tissues. So the sides of the heart determine where the blood will be pumped or which circulation it's going to go into. So as we take a closer look at how this works, we'll also see the path of blood flow throughout the heart. So let's start with the deoxygenated blood returning to the heart. So the superior and inferior vena cava are going to bring deoxygenated blood to the right atrium, and it's going to pass through the AV valve into the right ventricle. When the heart muscle contracts, the blood's going to be ejected through the pulmonary semilunar valve into the pulmonary artery, and it's going to go to the lungs. And so this is what we consider then the pulmonary circuit. Here, the lungs are going to exchange carbon dioxide for oxygen. As the blood goes then to and from the lungs, right here, we call this the pulmonary circuit. This newly oxygenated blood is going to return via the pulmonary vein to the left side of the heart, and it enters into the left atria. The blood's going to flow through the left AV valve and into the left ventricle. When the heart pumps again, the blood will be ejected through the aortic semivalve and into the aorta. And when it's in the aorta then, now it's considered to be in the systemic circulation, and it can then go to all of the other tissues of the body. Understanding these circuits will be important to our discussion about heart failure later in our module. We're next going to take a look at the intrinsic conduction system. Remember that muscle contraction is called excitation-contraction coupling, meaning that an electrical event is going to trigger the contraction in our myocytes. The intrinsic conduction system is a network of autorhythmic cells that can initiate and distribute impulses to coordinate the depolarization and contraction of the heart muscle. The autorhythmic cells can take over if there's no input to contract from the central nervous system. And there are 2 nodes that are important to the electrical system in the heart. The first is called the sinoatrial node, or the SA node, and this is known as the pacemaker. It generates impulses at about 75 times per minute, or what would give you a heart rate of 75 beats per minute, and we call that the heart's sinus rhythm. The AV, or the atrioventricular node, receives impulses from the SA node, and it delays sending that signal on, so it gives the heart a little pause. The signal, once it reaches the AV node, then travels down what we call the atrioventricular bundle, and this is really the only electrical connection between the atria and the ventricles. It then will branch, and it sends impulses to the right and left bundle branches that go down to the apex or bottom of the heart. And then the signal will go throughout the ventricles via what we call their Purkinje fibers. The path of an electrical impulse is going to start in the atria at that SA node. And so what we see is as that electrical impulse passes through the tissue, we see the atria contract first and then the ventricles. So they lag behind. So we were reviewing the conduction of the heart because defects can result in either arrhythmias or fibrillation. And we'll talk about those when we get to our pathologies. The cardiac cycle includes all of the events associated with blood flow through the heart during one complete heartbeat. When the cardiomyocytes are contracting, we call that systole. The contraction makes the volume of the heart's chambers smaller. It raises the pressure within them because as they get smaller, we're going to be having an inwards surge of pressure. And that is what causes the blood to be ejected. So think about squeezing a water balloon, right? You add pressure to the water in the balloon and it's going to squish to different directions. When the cardiomyocytes are relaxed, we call it diastole. The chambers are going to have room to accommodate the inflowing blood. This chart at the bottom of our slide sort of linearizes this cyclical pattern. So on average, the heart beats once per second. So you can see if we start our linear cycle here at 0, it's going to end at about 800 milliseconds, or approximately 1 second. We also have to track the difference between what's happening in the upper chambers, or the atria, versus the lower chambers, or the ventricles. So we divide our line here. The top is the atria, and what's happening on the bottom is what's going on in the ventricles. So as we start, blood would be flowing back to the heart. The contractile wave starts near the right atria, and the atria start contracting or undergoing atrial systole. At this time, though, the ventricles are in diastole, and that allows them to receive and fill with blood. The contractile wave is going to reach the ventricles, and then they're going to contract or undergo ventricular systole, and that's going to cause the blood to be ejected from the heart. And during this time, the atria return to diastole so they can start to refill with blood. As they are doing so, the ventricles also return to ventricular diastole and will start to refill with blood before the cycle starts again. Here we can see this as phases in picture form. So we'll start actually down here with picture 3 first. And these arrows are showing us that blood is returning to the heart and starting to fill the atria. The atria are going to start to contract, and as they do, it's going to force blood down into the ventricles, which are in diastole, and that's allowing them to start to fill. And so they're filling. Here you can see the AV nodes shut under that pressure, so we don't get a backfill of blood, and the semilunar valves are going to open as the ventricles contract, and that pushes the blood up into the great vessels. And during this time, our atria are relaxed, they'll start refilling, and then our cycle can start again. Since the cardiac cycle is key to the heart's functioning, many of the physiological measurements that we're interested in can be aligned to that cycle's events. For example, the chambers change in pressure and volume, the valves can open and close, the heart sounds in the ECG or electrocardiogram can all be assessed and aligned to that cycle. This chart aligns these processes for us. And it's a very busy chart. So it's worth it to pause when we're done taking a look at this and looking very closely at the axes of what you have going on here and the different measurements that this chart is aligning to our events during our cardiac cycle, which is also depicted here at the bottom. So we're going to take a look at this and walk through one event, basically, so you could see how to read this. And we'll take a look at the ventricles and when they're contracting. So here we could see the ventricles are contracting and we have ejection of the blood. So if we come up to our chart and take a look at then what's happening, at the very top, we see pressure. And so we see a big spike in pressure. Pressure is increasing as those ventricles are contracting, and that makes sense. We know that as the ventricles contract, it pushes out blood. And so the ventricular volume, or how much blood can be in there, decreases as that ventricle is squished and made smaller. So here, if we take a look at volume, during that contraction, we see a decrease in the volume. And that volume doesn't go up again until those ventricles start to relax and we see a decrease in pressure. As we move down our chart, then you can also see here's the ECG or electrocardiogram. And if you remember, the QRS wave shows us when the ventricles are contracting. And so you see that electrical conduction occurring right before we see the pressure increase or that contractile wave start. As well, you can see how the heart sounds align with the cardiac cycle. So here you can see when pressure pushes against the aortic valves, it causes them to open, and that gives us our heartbeat sound. So what you're hearing when you hear heartbeats are the valves opening and closing. So this first sound is that stereotypical lub of that ladub, ladub, ladub. And you can see that on our chart here. So remember that all of this gets started by that action potential or change in electrical flow throughout the heart that makes our cardiomyocytes contract. We're going to switch gears now and move away from our anatomy and cardiac cycle and now take a look at what regulates the cardiac performance. So we're going to look at 4 parameters of cardiac function. Each of these plays a role in how well the heart does its job, which is to act like a pump to push the blood through the pulmonary and systemic circuits. So the first important parameter is going to be contractility of the heart. If the contraction is too weak, not enough blood's going to leave the heart. And if the contractions are too slow or too fast, it will also affect the volume of blood that the heart can actually pump. So the next parameter is preload. If you remember, preload is the volume of blood in the ventricles that the heart has to eject. The volume of this blood is going to depend on how much gets returned to the heart via venous return and how much the cardiomyocytes can stretch to accommodate that incoming blood. The ventricles will be filled with blood at the end of their relaxation or diastole period. So the volume of blood in the preload is also referred to as the end diastolic volume. Preload is also related to contraction. The Starling law of the heart says that the contractile force of the muscle fibers depends on the amount of stretch they get prior to that contraction. So the greater the preload or end diastolic volume, the greater the contractile force is going to be. Afterload or resistance is our next parameter. Afterload is the pressure the heart exerts to overcome the blood pressure in the great vessels to be able to eject the blood from the heart. So there is pressure in those great vessels like the aorta that would work to push the blood back towards the heart. And remember, we only want to have a one-way path of blood. And so the heart has to work hard to be able to overcome this resistance or blood pressure. The last parameter is heart rate. An increase or decrease in that heart rate is going to be affecting the fill time of the heart, and thus it would affect preload and also contractility. So we can see that these parameters are interrelated and each play a role in affecting the heart's function, which is to move the blood into the pulmonary and the systemic circulations. So we're going to take a look at each of these more closely. Cardiac contractility deals with the ability of the heart to change its force of contraction independent of the diastolic length. So there are factors that can affect contractility. Inotropic effects are those factors that can influence contractility. So positive inotropic factors increase the contractile force. That can be input from the sympathetic nervous system, afterload, catecholamines like epinephrine, the heart rate, certain drugs, and intracellular calcium levels. Negative inotropic factors are those that decrease the contractile force. And those are things like the parasympathetic nervous system, heart failure, scarring from myocardial infarctions or heart attacks, hypoxia, which leads to less ATP generation, and again, certain drugs. Our next parameter is preload. Remember, by definition, preload refers to the stretching of the cardiomyocytes right before contraction. They're going to be stretched by the volume of blood that has filled the ventricle. And the Frank-Starling law of the heart refers to the principle that an increased end diastolic volume, which moving forward, because that's a lot to say, the end diastolic volume, know that that can be abbreviated EDV. So this Frank-Starling law of the heart, that refers to this principle that an increase in that EDV or end diastolic volume is going to cause an increased force of contraction. Thus, preload and the end diastolic volume are very closely linked. Another way of thinking of preload then is by thinking of it as the volume of blood the heart has to work with to pump. So there are factors that affect preload. The first is venous return. Venous return is that amount of blood that's brought back to the heart by the vena cava and the pulmonary veins each minute. And that can be influenced by blood volume, the musculature activity, and the rate of blood flow. So, for example, if blood volume decreases, then their venous return is going to decrease because there's less blood available to bring back to the heart. And so the preload decreases. Muscular activity is referring to your skeletal muscles and a person moving around. So if muscular activity increases, like during exercise, blood return to the heart is increased and preload will be increased. The filling time of the heart also influences preload. The filling time is where blood can flow in and fill the chambers during that ventricular diastole. If the heart rate is slow, there's more time for ventricles to fill, and so it increases preload. If the heart rate increases too high, then there's not going to be enough time to fill between heartbeats, and then there's going to be a lower preload. The afterload, remember, is the pressure that the heart exerts to overcome blood pressure in the aorta for the heart to be able to eject the blood that has collected in the ventricles. The greater the afterload means more work, or it's going to be harder for the heart to push out the preload or the end diastolic volume. Any factor that restricts blood flow in the arterial system is going to increase afterload. So for example, vasoconstriction or hypertension, which is when there's higher blood pressure, increase afterload. On the other hand, vasodilation decreases the afterload. So an increase in afterload increases the volume of blood left in the ventricles after contraction or systole. And that is called the end systolic volume, or ESV. The heart rate is the number of beats per minute. That's also known as your pulse, and it is influenced by many, many factors. So if we take a look, there are lots of factors that can affect heart rate. And it's good to come back to this chart later on in our discussion, and it's a good chart to come and study with, because you can see in the relevance column, there's the term CO, and that's referring to cardiac output, or the volume of blood that the heart pumps per minute. We're going to be looking at cardiac output in more detail momentarily. So that's why this is nice to come back to. But right now, we're just going to look at factors that affect the heart rate. So as you can see, the autonomic nervous system affects heart rate. The sympathetic will increase heart rate, where the parasympathetic system decreases our heart rate. Our body temperature can also affect heart rate. So a fever increases it, where hypothermia decreases our heart rate. With age in elderly patients, we generally see a decrease in our heart rate, but newborns have a much higher heart rate. Typically, if somebody does not belong to either of these populations, a typical heart rate we say is about 60 beats per minute. People with increased fitness actually have a decreased heart rate. So trained athletes have a lower heart rate, and that's because their heart is conditioned and it pumps more efficiently. So they have generally greater contractility. You can see thyroid hormone, if it's in excess, can cause an increase in our heart rate. And then different ion concentrations. Remember, our heart beats by electrical impulses, and that electricity comes from electrolytes or ions. And so different concentrations of different ions can disrupt our heart rate and cause different effects. So we're going to go ahead and define cardiac output that we had just talked about. Cardiac output is the volume of blood moved by the heart in 1 minute. So you could see in picture form. So if we were to calculate our cardiac output, we're interested in our heart rate, or the number of beats per minute, times our stroke volume. Our stroke volume is the blood pumped out by a ventricle with each beat. So it's a volume measure. So if you take how many beats in a minute times how much blood is leaving the heart with each beat, that gives us our cardiac output, or the volume of blood pumped by each ventricle in 1 minute. So we already have defined our heart rate. So let's take a look at stroke volume. So that's the amount of blood that's going to be pumped out by a ventricle with each of those beats. Let's look at the mathematical relationships here. So consider heart rate. If the heart rate increases, your cardiac output would increase. If this heart rate decreased, then our cardiac output's going to decrease. If stroke volume increases, cardiac output would increase as well. But if the stroke volume decreases, your cardiac output decreases. Picturing stroke volume can be difficult. So to help us with the concept, let's remember that it's the volume of blood pumped out of a ventricle with each beat of the heart. So the volume of blood in the heart after diastole gives us what the heart has to work with, or the amount of blood that can be pumped. The amount that remains after each contraction decides how much more blood can enter during the next cardiac cycle. So a good way to think about this is by imagining a bike pump, something that many of us are familiar with. So let's take a look at the bike pump as a visual aid to help us understand stroke volume and the difference between end diastolic volume and end systolic volume. So if we start at the top here, we can see as this pump handle raises up, it's creating a decrease in pressure inside the pump. And here, air, or you can imagine water, can flow down the pressure gradient and into this chamber. So that's similar to the filling of the ventricles during ventricular diastole. The water is going to continue to flow into the pump until it's full. In the heart, that would be considered the end diastolic volume, or EDV. So that's the amount of blood in the ventricle at the end of the ventricular diastole, and that's the same as preload. So think about preload now. It's what's preloaded, right? What's loaded, locked, and ready. Now, with contraction or movement, so here we have the movement of that pump handle downwards, the handle is going to move down and push the water or air out of the pump. And that's similar to the ventricular systole, and the blood gets ejected out of that ventricle. as the handle goes down as far as it can, there's always some residual air or water left in the bike pump. This residual in the heart is called the end systolic volume. So that's the amount of blood that would remain in the ventricle after contraction. So if we wanted to determine the stroke volume, or the amount of blood that was actually ejected, or we could say the amount of air or water ejected from this pump, would be the end diastolic volume, so what was preloaded, minus the end systolic volume, or what's left in the pump, and that gives us the amount that has been ejected out of the heart or out of this pump. So stroke volume equals the end diastolic volume minus the end systolic volume, and we can see the equation right here. We have to examine the mathematical relationship here. So if the end systolic volume increases, then stroke volume will decrease. So anything that affects either the EDV or the ESV is going to affect our stroke volume and then ultimately cardiac output. End diastolic volume is affected by two things: venous return. So if more blood comes back to the heart, then the venous return increases. If less blood comes back because of bleeding or stasis and mobility, then there's a lower end diastolic volume and a lower stroke volume. The other factor that can influence end diastolic volume is filling time, and that's the time between ventricle systole. So the greater the fill time, the greater the end diastolic volume. So another way to think about it is a slower heart rate allows more time for blood to come back into the heart. If that fill time gets shortened because heart rate is going very, very, very quickly, the end diastolic volume will decrease and stroke volume then decreases. For end systolic volume, two factors again. So here, greater contractile force is going to eject more blood from the chambers, and that decreases the end systolic volume, which will increase the stroke volume. Having a weaker contraction will do the opposite and decrease the systolic volume. A greater afterload, for instance from vasoconstriction or higher blood pressure like hypertension, is going to cause more blood to remain in the heart, and that increases the end systolic volume, and then that decreases stroke volume. Remember, stroke volume will influence our cardiac output. So an increase in the stroke volume increases our cardiac output, but a decrease in stroke volume is going to decrease the cardiac output. So there's a lot of increases, decreases, and influencing this and that as we look at cardiac output. So a nice way to take a visual in is to lay this out in a concept map. And so I've put one together here that looks at the things that can influence heart rate and the things that can influence stroke volume. And with stroke volume, then we break it down into the end diastolic volume and the end systolic volume. So it's always good to come back to the basics and remember, if heart rate goes up and down, what does that do to your cardiac output? If stroke volume goes up or down, how does that influence cardiac output? So I would encourage you to pause the video, and in this we have laid out the different factors that we have talked about and how they influence our cardiac output. You can stop and think and say, well, what would happen if, for instance, temperature goes up and heart goes up? What would that do to my cardiac output? Can you think of it, for instance, when body temperature increases, like during fever or if someone is overheated, etc.? So I'm not going to walk through every single thing on this slide because we have covered it, but this is a good review study slide that I've put together for you. And so use it at your leisure and to help